Hey, good morning, everybody. Thank you very much. That was a fantastic talk by Dr. Kettler. So I know that your brochure says Dr. Sharon Moe. I can assure you that I'm not Sharon Moe. Unfortunately, she's not able to be here today, so I'm filling in for her. These are her slides, which I received about a day ago. So we're going to talk today about PTH, vitamin D, and bone health in CKD patients not on dialysis. And to follow up with Dr. Kettler's talk, we're going to be reviewing two guidelines. So what is CKD-MBD? It's a systemic disorder of middle limb bone due to CKD. And it's manifested by a combination of abnormalities in calcium, phosphorus, PTH or vitamin D metabolism, abnormalities in bone turnover, growth, mineralization, and vascular or soft tissue calcifications. PTH is a uremic toxin, and we know that after parathyroidectomy and when we take away the PTH, that a number of its toxic effects are also relieved. For example, bone pain dissipates, muscle strength improves, pruritus may go away, anemia may improve, mentation improves, sexual function improves, and sometimes blood pressure and cardiac output may also improve. So our goal is to treat secondary hyperparathyroidism in the CKD, and we need to understand what and why we are treating this disorder. And are we treating the PTH to normalize its levels, or are we trying to prevent end organ damage? And then there are some important questions that we need to think about, such as when do we start? When the PTH is above the normal range, when PTH is at a level associated with abnormal bone histology, should we be treating based on the FGF23 level, or should we be waiting until the patients become hypocalcemic? And then once we decide when it's time to treat, what do we use? Should we be repleting with parent or nutritional vitamin D? And then what kind of active vitamin D should we be using once we reach that point? I'm going to try and address some of these questions today in light of the updates to the KDIGO guidelines. So in 2013, we have a guideline on treating PTH, and the old guideline is as follows. In patients with CKD stages 3 through 5 not on dialysis, the optimal PTH level is not known. However, we suggest that patients with levels of intact PTH above the upper limit of normal for the assay are first evaluated for hyperphosphatemia, hypocalcemia, and D deficiency. And it was also stated that it is reasonable to correct these abnormalities with any or all of the following by either reducing dietary phosphate intake, phosphate binders, calcium supplements, and or native vitamin D. And this recommendation was not graded. The 2016 update to this guideline is as follows. In patients with CKD stages 3A through 5 not on dialysis, the optimal PTH level is not known. However, we suggest that patients with levels of intact PTH that are progressively rising or persistently above the upper limit of normal for the assay are evaluated for modifiable factors, including hyperphosphatemia, hypocalcemia, high phosphate intake, and D deficiency. And why was that update decided upon? Well, the working group felt that modest increases in PTH may represent an appropriate adaptive response to declining kidney function, and we revised this statement to include persistently above the upper normal PTH level, as well as progressively rising PTH levels, rather than above the upper limit of normal, and that is because treatment should be based not on a single elevated value. So what drugs do we have that lower parathyroid hormone? We have armamentarium, we have vitamin D, so we have Parent D, Ergo and Chole. We have vitamin D prodrugs, and then we have active vitamin D analogs, and then we also have calcium mimetics. And these all reduce PTH levels. There are multiple studies that one can review. However, in general, PTH is reduced by about 40 to 50%. By using any of these drugs. And after these drugs are administered, there are some considerable complications that one needs to occur. For vitamin D analogs, one needs to consider the incidence of hypercalcemia, and in several studies it's been demonstrated, as demonstrated here in this slide, in both pre and post-treatment in green and pink, and then compared to the placebo groups in red and brown, that in patients who received a vitamin D analog that there were increases in calcium, and then of course it's in a calcet after administration of the drug there was a decrease in serum calcium. And then also one needs to consider the incidence of hyperphosphatemia. So with administration of a D analog, serum phosphate levels did increase, and then not surprisingly also if it's in a calcet in pre-dialysis patients, serum phosphate levels did also increase. So regarding treatment and regarding our data on the end organ effects of treating patients with hyperparathyroidism, we have a problem. So we have no hard outcome data for fracture reductions, for mortality, for bone hysteromorphometry that were able to meet inclusion criteria for the KDIGO updates. So we consider several trials that have recently been published, in particular the PRIMO trial and the OPERA trial. These studies administered paricalcitol to patients for periods of 48 and 52 weeks respectively, and they both resulted in a biochemical response to drug treatment, as demonstrated here. In the PRIMO trial, there was a reduction in PTH compared to the placebo group, and in the OPERA trial, we saw a reduction in parathyroid hormone and in bone alkaline phosphatase in the treatment group. However, when it came to their primary outcome, which was cardiac structure, in both of these studies, there was no difference in left ventricular mass index by MRI. So this was a negative study. And then we need to also consider the complications and the risk of hypercalcemia that result from treatment with paricalcitol. So in both studies, for example, in the PRIMO trial, there was a mean increase in serum calcium of about 0.32. And there was also an increase in serum phosphorus by about 0.2, and the incidence of hypercalcemia, defined as a serum calcium level of greater than 11 micrograms per deciliter, was about 1/4 of the patients. In the OPERA trial, similarly, there was increased serum calcium, increased serum phosphorus, and also an incidence of hypercalcemia of about 40%. So when we consider treating our patients with these medications, we need to really consider the risk-benefit ratio, and is it reasonable to give our patients these drugs in the absence of hard clinical endpoints? So in summary of PTH lowering with calcitriol and analogs, in KDIGO 2009, it was stated that there was a lack of RCT data in patients with CKD stages 3 through 5D that directly shows that the changes in PTH with vitamin D leads to improved clinical outcomes or adequately describes potential harms. And the 2016 update states the following. In summary, the PRIMO and OPERA studies failed to demonstrate improvements in clinically relevant outcomes, but did demonstrate increased risk of hypercalcemia. Therefore, the guideline was changed to, an adult patient with CKD 3A through 5, not on dialysis, we suggest calcitriol and vitamin D analogs not be routinely used, and this was graded as 2C evidence. And it is reasonable to reserve the use of calcitriol and D analogs for patients with CKD stages 4 and 5 with severe and progressive hyperparathyroidism, and this recommendation was not graded. So when you do decide to initiate treatment with a D analog, which do you use? And there was an RCT that compared the efficacy of paricalcitol versus calcitriol in CKD patients stages 3 and 4 who had intact PTH levels above 120 picograms per ml. And as demonstrated here in this slide, there was equal efficacy between these two drugs in lowering PTH levels by 24 weeks. And then when the incidence rates of hypercalcemia and hyperphosphatemia were compared, it was shown that by 24 weeks there was equal incidence of increases in levels of serum calcium and also serum phosphate. So moving on to the next recommendation, which specifically addresses the bone disorder of renal osteodystrophy, or CKD-MBD, which is renal osteodystrophy. So renal osteodystrophy is an alteration of bone morphology in CKD patients. And it is one measure of the skeletal component of CKD-MBD, and it's quantifiable by bone biopsy with histomorphometry. Our hard clinical outcome for the bone component of CKD-MBD is fractures. And this is an important outcome because it leads to increased risk of hospitalizations, quality of life, and more than a doubling of mortality risk. Our CKD patients, regardless of their stage of renal failure, are at an increased risk of fracture. And there's been a ton of epidemiologic data over the past 20 to 30 years in this field in both patients on and off dialysis. And this was a slide that we made up for a recent editorial on risk of fractures in the population. And you can see here in green on the bottom is our reference general population, which comes from the Rochester, Minnesota databases. And these are patients that are healthy with healthy kidney function. And you can see that is renal function progressively worsens, that the risk of fracture just keeps going up, and that's also occurring as they age, even at higher fracture rates. And not shown in these data sets, or that other recent epidemiologic data also demonstrates that over the past 20 years, fracture rates have gone up in our ESRD populations, in particular among our Caucasian patients. So our patients are at increased risk of osteoporosis and vice versa. These are older data from about 15 years ago from NHANES. And what they show in this histogram are that patients with osteoporosis, women on top, men on bottom, the patients with osteoporosis are here in black, osteopenia in gray, and patients with normal bone mineral density are in white. And GFR, or here it's creatinine clearance, is on the bottom. And what you can see is that the burden of osteoporosis is occurring in our patients with renal failure. And then when we look at this Venn diagram, you can see that in terms of where the osteoporosis patients fall in terms of their renal function, the majority of them in the general population are occurring in our patients with CKD stages 3 and 4. So it's something that we really need to be aware of, in particular in light of how these guidelines will change in the future. So what is osteoporosis? So quick for definitions. Operationally, it's defined on the basis of bone mineral density, and the World Health Organization has stated that osteoporosis is defined as a T-score of less than -2.5. A more exact definition is that it's a skeletal disorder characterized by compromised bone strength that predisposes to an increased risk of fracture. What's bone strength? Bone strength is a combination of two features of bone. It's quantity, or it's bone mineral density, or it's quality. And bone quality is a very general term that applies to bone material properties. Risk factors for osteoporosis are multiple. Previous fractures, low peak bone mass, and genetics. Our ethnicity defines our risk. Physical activity or being non-weight bearing, our risk for falling, hormone deficiencies, alterated collagen structure, smoking, alcohol, so various behaviors, and of course altered bone turnover. And renal osteodystrophy is a form of osteoporosis that is due to fragility from abnormal bone microarchitecture. So that gets us back again to what is bone strength. And the American Society of Bone and Mineral Research has defined this as a combination of quantity and quality. So once again, quantity, we measure the mass of bone by DEXA. Bone quality, as I stated previously, has to deal with bone material properties in terms of bone's turnover, so resorption and formation. Its macroarchitecture, or its geometry, how big is your bone? Microarchitecture, so the structure of the trabecular network, how porous your cortex is, and then other properties of that bone, such as how well it's mineralized, whether or not there's cross-linking within the bone that's abnormal, and whether or not the bone has an adequate response to microfractures. This is assessed, as I stated before, by bone biopsy, maybe by bone biomarkers. However, that remains to be determined. We can also assess bone quality by other advanced imaging methods such as micro-CT or HPLC. And then bone quantity we can assess by DEXA and QCT. So how do we diagnose this disorder? Okay. And is there a non-invasive way by which we can diagnose renal osteodystrophy? There are multiple imaging studies out there that have now demonstrated to us that we can at least assess fracture risk in our CKD patients, and these studies led us to revise the second guideline. So we know that we can measure bone density by DEXA, and you can also measure cortical and trabecular density and microarchitecture by higher resolution imaging such as QCT. However, the other components of bone quality that are also very important at this point in the game can only be measured by invasive bone biopsy. So turnover, microarchitecture, matrix composition, microfractures and mineralization all require a bone biopsy. We do know that there is, as I said, excellent data out there showing that DEXA can help us assess fracture risk. And these data come from the Health ABC study. Here we have patients who had their bone density measured, and they were followed prospectively. There are patients here with no osteoporosis and no CKD, followed by no osteoporosis and CKD, followed by osteoporosis, no CKD, and osteoporosis with CKD. And I think that what's clearly apparent is that those patients who have osteoporosis with CKD have the highest risk of fracture, but also we see that those patients with CKD in general, such as here, even without osteoporosis, have a higher risk than those patients without CKD, without osteoporosis. The main limitation to the study, though, was that the subset of patients with renal failure was small. It was only 4%, and only a minority of the patients had abnormalities in PTH. So this is one limitation that we need to consider when evaluating this study and the strength of its message as we rewrote the guideline. Other studies also, though, in patients truly with CKD, such as this study from Sarah West in Toronto, which was recently published about 2 years ago, included patients with pre-dialysis CKD, the majority of which had stages 3, 4, and 5, and they did have biochemical evidence of renal osteodystrophy. And what they demonstrated was that in adjusted models, the ability of DEXA at the hip, spine, in particular at the radius, both the ultradistal and the 1/3, predicted fractures with an excellent AUC. And then by HRP-QCT at the radius, measuring the area of the cortex, which is consistent with hyperparathyroidism and its effect on bone, was excellent at also predicting future fractures. And then other data coming from our group have shown that over time, the main effect of renal failure on the skeleton is in the cortex. And these data demonstrate that over a period of about 1.5 years, that there were significant declines in DEXA at mainly cortical sites. So the total hip, probably about 50% cortical bone, and the UDR is also about 20% cortical bone. And then here we saw significant decreases in radius cortical BMD, tibia cortical BMD, and cortical porosity at the radius over time. So based on these data, this old guideline was updated. The old guideline stated that in patients with CKD stages 3 through 5D, with evidence of MBD, we suggest that bone mineral density testing not be performed routinely, because BMD does not predict fracture risk as it does in the general population, and BMD does not predict the type of renal osteodystrophy graded as 2B. At this time in 2009, when this guideline was written, there were no prospective studies on the utility of DEXA in our patients. The new guideline now that's out for review states the following. In patients with CKD stages 3A through 5D, with evidence of MBD and or risk factors for osteoporosis, we suggest BMD testing to assess fracture risk if the results will impact treatment decisions, also graded 2B level evidence. And the reason why this guideline was updated are that multiple new prospective studies have documented that lower BMD by DEXA predicts incident fractures in our patients, and further, that the risk of fracture is increasing despite aggressive or over-aggressive treatment with PTH. So regarding treatment, I think that's the elephant in the room. We're told now that potentially we may need to be getting DEXAs in our population, but then what do we do about it? And in light of the fact that there are no RCTs suggesting to us what can be done, we only can rely on secondary analyses of the main prospective studies of anti-fracture therapies in the general population. So all of these studies, which were the main registry trials for bisphosphonates, denosumab, and teriparatide, had a exclusion criteria for renal function based upon the serum creatinine. As we know, when you plug that number into a GFR estimating formula, some of the patients are going to have CKD just based upon GFR alone. So all of these secondary analyses looked at patients who had GFRs of less than 60. None of them, though, had abnormalities in PTH or D because they were exclusionary criteria for these RCTs. But what we can glean from these data are the following. So when we look at the bisphosphonates, at here alendronate or Fosamax, and here residronate or Actonil, and the patients who had renal failure, whether it was CKD stages 3 or 4 or less than 45 mLs per minute, that there were reduced rates of fracture for these patients treated with bisphosphonates. For raloxifene, which is a SERM, there was also a reduced risk of fracture in treated patients compared to the placebo group. With denosumab, which is a very promising new anti-resorptive, and unlike the bisphosphonate that's not renally cleared, so it may be safer for us to use in our patients. There was also positive results indicating that rates of hip fracture and spine fracture were reduced. And for teriparatide, which is a form of intermittent PTH, the data was also suggestive of a benefit. However, these patients didn't have enough severe CKD for us to know whether or not this could be used in our patients with CKD stages 4 or 5. So what do we do regarding treatment of mineral and bone disease or bone disease in our patients? Well, now we know that a very low BMD test by DEXA or by CAT scan correlates with an increased risk of future fracture. We still recommend that you should optimize MBD management, whether it's through calcium, phosphorus, or vitamin D management. We should optimize risk factor reduction. So we should stop PPIs, encourage weight-bearing exercise, encourage good nutrition, risk assess our patients for falls, ask them to quit smoking and reduce their alcohol intake, and limit their exposure to steroids. And then we should consider risk of therapy versus potential benefits of having them increase their bone mass. And ultimately, because of the lack of RCTs for our patients, it's really hard to give you all good evidence-based guidelines. And what we really need is a call to action, and we need to have RCTs in this patient population so we can reduce their risk of fractures and mortality. Thank you very much.
Thank you. We have a couple of minutes for questions. Yes, go ahead.
Thank you for the great presentations. One question you did mention in your last slide about decreasing the other risk factors for fracture, but most of the studies that you showed, they are giving evidence for fractures as only osteoporosis, whereas something like fall can act as a confounding factor. For example, if your calcium is lower, or maybe if your CKD stage is going up, you may have more falls because of lack of strength, lack of balance, or other causes. In that case, probably your diagnosis and even intervention might be different to decrease the fracture rather than just focusing on bone density. Can you comment on that, please?
So that's a great question. So fall risk is a very important predictor. There are some studies in renal failure patients showing that fall risk is a better predictor of fracture than bone mineral density. There are studies out there in randomized trials, not in renal failure patients, about hip protectors. These are, it's like underwear that's padded over the hip area, and when they're used correctly, they can result in a significant reduction in fracture risk. Other things that can be done for fall risk are, of course, encouraging better nutrition and referring your patients for physical therapy. I'm not sure if that answers your question.
Question to Dr. Marks, please. You said that we should not do preventive treatment for hyperphosphate normal in stage 3 and 4. And we know that patients entering dialysis have sometimes normal phosphate and they have calcification, and that high normal serum phosphorus is associated with increased mortality. So patients entering dialysis have normal phosphate, high PTH, and the calcification, and now we hear we should not optimize phosphorus or keep it to the low normal and leave it so long it is within normal range.
It is a bit difficult to understand, but I think what you're saying is that vascular calcification is a risk factor also in patients not on dialysis, and that they may benefit from such treatments. However, the group we investigated were indeed patients with a normal phosphate or a high normal phosphate and calcifications, and the progression in these patients was indeed shown in patients who are on the phosphate binders, especially on the calcium. So maybe the mechanisms between patients in early stages of CKD and on dialysis may be a bit different.
No, I am only talking about patients not on dialysis.
Yeah.
And do you know that high phosphate level in these patients is associated with increased mortality? Many studies showed that. And they have increased incidence of calcification pre-dialysis.
Yeah.
And they enter dialysis sometimes with normal phosphate and high PTH. And now we hear that we should not control or pay any attention to serum phosphorus so long it is within the normal range. That's what I'm right that you said that?
I will try to answer your question. So I think what you're saying is that there is a strong association between high serum phosphate and high mortality in pre-dialysis.
No, high normal, not high.
Higher mortality in pre-dialysis.
High normal phosphate.
Right.
Not high phosphate.
Okay, high normal phosphate. So the new guidelines are saying if the phosphate is rising over time, so you check it a few times and it's rising in a patient, then consider phosphate binders, but not as a preventative measure. That's the update.
Okay, thank you.
Hi, thank you for the presentations. I have two questions. One is there a definition for calcium restriction in terms of total daily dose to utilize as binders? And is there then, if you just have an environment where many of our patients can only take calcium-based binders because of cost or availability issues, do you have a recommendation on essentially ignoring the hyperphosphatemia if you're on a peak dose of calcium? The second question relates to osteoporosis risk, and in those patients who are CKD3, whom we wouldn't want to use vitamin D activated analog. Is there a recommendation in terms of comparing them or treating them like the general population and giving them vitamin D2 or vitamin D3?
Maybe the last question first. Vitamin D2 and D3, the recommendation is adapted from the normal population, and the point that it was not mentioned here is that it will be maintained from the previous guideline. So supplementation, replacement is still quite strongly recommended to levels of above like 30 nanograms per ml, for example. Concerning the calcium restriction, the nature of the KDIGO guidelines is, of course, really very much based on the guidance of the evidence review team. So by epidemiologists, biometric people who tell us where the evidence is sufficient to give you, for example, numbers or cutoffs or whatever. This is not possible here. What we know is that these studies that indicate a risk for mortality with the calcium-based binders always used very high doses because these were quite highly up-titrated. But to calculate a level that is toxic or non-toxic, especially in the CKD patients not on dialysis, was not really possible. The point is that these studies that we look at now in patients not on dialysis is that it seems to be that they are prone to develop quite a positive calcium balance, and at least there is one RCT that shows that there is an immediate progression of calcification in these patients, and this is why we are very careful here. But whether you could give, for example, a low dose of, I don't know, less than 1 gram total per day cannot be stated. In dialysis patients, there is some evidence that shows that if you lower the phosphate also with calcium-based binders to a possibly moderate dose, that this is better than not treating hyperphosphatemia at all. But obviously, there may be a difference between these two stages of CKD, and the attempt in these guidelines was to refer to the best quality studies that allow us to make a statement at all.
Thank you for the talk. I just have a question regarding therapy. I have several patients with CKD3 that come to me with very abnormal DEXA scans consistent with osteoporosis. They have very mild PTH elevations, maybe slightly hypocalcemic. As I understand it, bisphosphonate therapy, the risk is adynamic bone disease. Can you comment on the therapy, bisphosphonates, for those patients? And the practicality of doing a bone biopsy is not really practical. And you showed data that CKD patients lose cortical mass, and if they have other reasons to have osteoporosis, they're going to continue to lose bone mass. May you comment on the therapy?
Yeah, this is a big moving target in regards to what to do. So typically we always say, if your patients are hyperparathyroid and have abnormalities in calcium and phosphorus, that should be corrected first. In a CKD stage 3 patient, I think it's a little easier because you still have adequate renal function to clear the bisphosphonate. I mean, the issue with the bisphosphonates are that they're cleared by the kidney. They get laid down into bone hydroxyapatite, and once GFR gets low, like lower than 30, then it just hangs around for a long time. So you may be inducing low turnover bone disease, and that may be bad. We think it's bad. We're not quite sure. For a CKD stage 3 patient, it's a little easier. I think that you can be comfortable giving your patient with osteoporosis a bisphosphonate as long as the other MBD stuff is corrected. So you don't want to give a bisphosphonate if you think that there's osteomalacia. And in somebody with hypocalcemia and low vitamin D, that has to be a concern. So there's no guideline for this. There's no standard approach, but what we're typically doing is, in those kinds of patients, we'll correct that abnormality for at least 6 months before we consider starting a bisphosphonate or another anti-resorptive.
Okay. Correcting it meaning giving activated vitamin D or?
So typically I would start with correcting the vitamin D. And once the vitamin D level is corrected, sometimes the PTH levels, corrected with 25, with D3. I would start in CKD stage 3 with Chole or Ergo. I would get the D25 level above 30. And then I would monitor the PTH, see if it normalizes, and then at that point, after about 6 months, when I'm comfortable that the bone has had time to mineralize, I would start a bisphosphonate.
Okay. Thank you very much.
You're welcome.
In continuation to the last question asked, I wonder why the update suggests that you'd like to do BMD studies in patients with CKD 5 and 5D, because neither can we use anti-resorptive therapy as denosumab or bisphosphonates in this group of patients. So what is the point in doing BMD studies in patients with CKD5 or 5D?
Okay, so we can use DMAB in our patients, and I think that we can use bisphosphonates also. There are data using IV bisphosphonates on kinetics in dialysis patients, and they are cleared by the membrane. In terms of denosumab, it's not renally cleared. I mean, it's a monoclonal antibody, and it just dissipates over a 6-month time period. The risk concerning denosumab in renal failure patients are that when you shut off osteoclast function in a patient with hyperparathyroidism, it's like giving them a parathyroidectomy. They develop hungry bone syndrome, and then they become hypocalcemic, and that's just one of the things that we need to be aware of. We need to be able to risk assess for fractures, first of all. We know that it's a problem. We know that our patients are not being treated because we're not screening, and we know that over the past 20 years, fracture rates are going up in our patients. They're not going down. In the general population, over the past 20 to 30 years, they've gone down significantly, but not in ours. And we know that after a fracture, if you take an ESRD patient on dialysis, they have a fracture, compared to their non-fractured colleague, their risk of mortality doubles. Put that on top of their already 25% mortality rate per year. That's too high. So without risk assessing, then we can't go to the next step of designing clinical trials. So we have data now showing that DEXA works in our patients. There's data in both pre and post dialysis. What we need now are therapies.
So would I be correct in understanding that in a patient with CKD5D, if you find the BMD the T-score is minus 2.5, you would advise use of bisphosphonates or denosumab? If their bone density demonstrates osteoporosis, there are studies out there that do demonstrate that they're at a higher risk of fractures. They weren't reviewed in today's talk because we were focusing on pre-dialysis. However, there are studies out there that are prospective that show that fracture risk increases. And then we need to decide how to treat them, which is a very complex matter. It's hard. I mean, you're noting the complexity of what's the bone turnover. And we treat the osteoporosis or the bone disorder based on the bone turnover. In patients with hyperparathyroid bone disease, you want to slow it down. You want to treat the PTH, manage the phosphorus, and maybe start an anti-resorptive. In patients with adenonic bone disease, we may want to give them back more PTH with teriparatide. But these studies need to be done. Right now, we're doing this on an ad hoc basis, just based on patient profiles on an individual basis. But we do need RCTs to demonstrate efficacy and that we're not harming our patients. Thank you.
You're welcome.
I think we'll end here. You can come up to the podium to ask your question. Thank you very much.